All right, welcome to our ankle and lower leg PowerPoint. We are going to start off by talking about the anatomy, going over bones, joints, ligaments, and then muscles and compartments of the lower leg. So as you can see here, we have two images of the ankle joint. We are going to focus on tibia, fibula, talus, and calcaneus today because those four bones make up the two joints of the ankle. All right, so the two major joints associated with the ankle movement are going to be the talocrural joint and the subtalar joint. The talocrural joint is the true ankle joint, and this consists of the talus and medial and lateral malleoli. So if we go back for a second, the medial malleoli is the part of the tibia that sticks out on the medial side of your ankle. So if you go and feel on the medial side of your ankle, that is your medial malleolus, and that's a part of the tibia. Whereas on the lateral side, the bone that sticks out, that's your lateral malleolus, and that is just a portion of the fibula on the lateral side. Movements that the ankle joint does are plantar flexion and dorsiflexion. I have a video up in this week's module that can explain those motions better for you, and that will give you a visual to those movements. The subtalar joint is going to be just below the ankle. The bones are the talus and the calcaneus, and at this joint we have inversion and eversion, which is moving the foot inward and outward. Ligaments, we have on the medial side something called the deltoid complex, which is made up of 4 different ligaments. You don't need to know the individual ones, but I do want you to know that the deltoid complex is on the medial side of the ankle. And on the lateral side, we have several different ligaments that are very stabilizing, and they're also more commonly injured because of the location and movement of the ankle. So on the lateral side, we have anterior and posterior tibiofibular ligaments, anterior and posterior talofibular ligaments, and the calcaneofibular ligament. So here we just have some images of that. If you guys haven't noticed, the name of the ligament really tells you the location in which bones it's attaching to. So for example, on the bottom right, we have the anterior talofibular ligament. Anterior means it's going to be toward the front, and talofibular means it connects the talus to the fibula. So as long as you guys refer back to those anatomical terms as well as knowing the bony anatomy, that'll really help you locate these ligaments. And here are just more images. We have both lateral and medial sides of the ankle. All right, for muscles, this looks like a daunting long list. We do not have to know all of them for this class. It's a little bit advanced, but I am going to talk about the 4 muscles in the middle. So starting with tibialis anterior, soleus, gastrocnemius, and tibialis posterior. Those are the ones we're going to focus on for this class. For compartments, we have our lower leg divided into 4 different compartments, and in each compartment is going to be different muscles, veins, arteries, nerves, and bones. So we have the anterior, the lateral, the deep posterior, and the superficial posterior compartments. In those big white triangles, the bigger one is going to be the tibia, and the smaller one is going to be the fibula. And then we have blue, red, and yellow circles. Those are going to be our arteries, veins, and nerves. And this picture right here is looking at a cross section of our lower leg. So if we cut straight through our calf muscles, this is what we'd see on the inside. All right, so to prevent lower leg and ankle injuries, similar to preventing foot injuries, which would be heel cord stretching, making sure we're doing strength training and neuromuscular control, proper footwear, and then if need be, ankle taping and bracing. To assess the ankle, we're going to follow our same HOPS plan. And then for some special tests, we won't learn all of these, but we have the bump test, anterior drawer, Taylor tilt, and then one at the end of this lecture that I'll go over. For ankle sprains, inversion is going to be our most common way that we sprain the ankle, and that's just because there's a lot more movement. Inversion is bringing the bottom of the foot inward and that's how we most commonly will injure our ankle. Then we have eversion, which is bringing the bottom of the foot outward. And then we have something called a high ankle sprain, which is the tissue between the tibia and fibula, right above the ankle, that can get damaged. And we are going to grade these grade 1, 2, and 3. So grade 1 being an overstretch of the ligament, grade 2 is a partial tear, and grade 3 is a complete tear of that ligament. Ankle fractures. The most commonly fractured bone in the ankle is going to be the fibula, so our lateral shin bone. And that's just because it's a lot thinner, it's weaker, and the position is going to make it more susceptible to fractures. We can also fracture our tibia, but as you can see, it's a lot thicker at the base, it's larger, it's stronger. Sometimes you'll fracture both at the same time, but usually our fibula goes first. And then you can also fracture your talus, which is the large bone right underneath that joint. Tendinitis, which I'm sure you guys have heard of, it's very common. It's an overuse chronic injury, and it can happen to any tendon in the body, but where we're going to focus on for this class is going to be on the anterior and posterior tibialis tendons, the peroneal tendons, which are on the lateral side of your calf, and your Achilles tendon, which is the thick heel cord that comes down and attaches to your calcaneus bone. Okay, for leg fractures, we have an image here of a football player getting tackled. This is very common. It's happened already this season in football. It can happen in basketball, baseball, like sliding into home plate. Really, it just happens from any sort of blunt trauma. And then we can also have stress fractures, which build up over time, and those are overuse injuries. Shin splints, I'm sure you guys have also heard of this one. Shin splints is not a medical diagnosis, it's just kind of a term for all kinds of anterior lower leg pain in the front of the shin. We do have a medical term called medial tibial stress syndrome, and this is the more descriptive way to explain shin splints because it's talking about the different areas and structures that can be under stress. So we can have stress fractures, compartment syndromes, or tendinitis. Causes for this are going to be poor foot mechanics, tight heel cord, maybe muscle weaknesses, of course improper footwear, just like our foot conditions, and if we are running on constant hard surfaces that don't have a lot of give to them. All right, then we also have something called compartment syndrome. This is where you have an increased amount of pressure within one of those 4 compartments that we went over in the lower leg. So this usually happens from direct trauma. Maybe 5 or 6 years ago, it happened, I think, to a Dodgers baseball player getting hit by a line drive in the calf. That is going to cause a lot of swelling, and it'll increase the pressure within the compartment. Now, the problem with this is that around each compartment, there is connective tissue called fascia that kind of acts like a cellophane or saran wrap around that compartment, and it does not allow the pressure to release or go to different areas. So once it's there, it's very hard to get rid of. And if the pressure keeps increasing, we can get a lot of damage that could potentially lead to losing your foot or leg by compressing on the nerves and blood vessels in the lower leg. It can also happen by repetitive activities such as running or jumping. Treatment for this is going to be resting, and then in very severe cases, you can decrease the pressure by having surgery in what's called a surgical fasciotomy. Signs and symptoms for this are going to be that the leg is warm and tender, immediate swelling with a sensation of being very tight or swollen, puffy feeling. They're going to have weakness in dorsiflexion, which is bringing your toes up towards you. They will have numbness and tingling in their foot, and that's because the pressure is occluding those nerves. The foot might become cold or even lose its pulse. So these last 2 are because the swelling is so severe that it's pressing on the veins and arteries and not allowing blood to go into the foot or come back up to the heart from the foot. This is a medical emergency because it can stop blood flow and potentially lead to loss of limb. On the left, we have an image of just a swollen calf muscle and then the anatomical cross section in the middle, showing that it's compressing those vital arteries, veins, nerves. And then on the right, we have an image of what a surgical fasciotomy looks like, cutting open the leg, depending which compartment it's in, different areas, and then allowing the pressure to release that way. Okay, so we talked about a few muscles and tendons that can get tendinitis. Achilles tendinitis is probably one of the most common, so we're going to focus on that one today. This is an overuse chronic injury. It doesn't just happen in one day, it happens over time. Signs and symptoms are going to be pain with movement or stiffness in the back of the Achilles, a weak push-off, which means it's weak or painful for the athlete to push off their toes quickly. Function usually improves with heat, so as the muscle warms up throughout the day or if we put a hot compress on it. They'll be point tender, meaning it hurts to press right on the tendon, and then they can have something called crepitation, which is like a crackling sensation because of swelling. Treatment for this is going to be heating the injury before and using only cryotherapy afterward, so ice or cold whirlpool. You can use NSAIDs for pain and swelling. You can put in a heel lift, which is a small piece of plastic or foam in the heel of the shoe that is going to decrease dorsiflexion, so it'll make the heel slightly raised, and that can help take pressure off of the Achilles tendon. We're going to have to modify activity, so less reps, less distances, slower running, whatever that athlete is doing. We can do an Achilles tendon tape job, which is going to help provide support for that tendon. And then, of course, increasing flexibility is really, really big, making sure the calf is always loose and stretched out. To correct the problem, changing shoes if we need to, again, increasing flexibility, and then we can use orthotics if we need to return the foot to a neutral position. This is an image here of what Achilles tendinitis looks like. Basically, over time, due to swelling, irritation, or tightness, the tendon is going to degenerate over time, so that looks like little bits of fraying or inflammation on the individual fibers, and that usually happens right at the base of the Achilles tendon, right where it is attaching to our calcaneus bone. Okay, now we can also have an Achilles tendon strain or rupture. So instead of being something that's chronic, this is going to be acute, which means it happens at one time. You can pinpoint the exact time that it happened, and it's not something that's going to get worse over time. This usually happens in adult males over 30, and that's just because as we age, our tendons become less elastic. It's caused by a sudden, forceful plantar flexion, so that means pushing off really quickly off your toes in a sprinting motion. This usually happens with very ballistic, quick movements such as tennis, racquetball, and basketball motions. The person will describe hearing a pop and feeling as if they were kicked. It's usually a very loud injury because it's such a big tendon, and the person feels like they were kicked or shot in the back of the heel, and they usually fall down immediately because they don't have any lever system to be able to push off of that foot anymore. And then something called a positive Thompson squeeze test. The Thompson test is our special test for the Achilles tendon, and we have images right here. So for a Thompson test, a normal Achilles, if someone's laying down on their stomach and you squeeze the calf muscle, their toe is going to point slightly. So it's going to move a little bit because it's attached via the Achilles tendon. A positive test, which is bad, it means a person has a torn Achilles tendon. You squeeze the calf and their leg is relaxed and the toes do not move at all. So the ankle stays completely still and they're not going to move into plantar flexion.